Our group is covering the standardization of evidence-based treatments and its effects on the instruction, treatment, and outcomes of children and youth with disabilities. I'm Michael Finn. I'm going to be the moderator and stater, and Melissa Boatman is the prover, and Galen Black is the attacker.
The argument for pro is the use of evidence-based treatment is essential in proving floor for treatment selection. This evidence-based studies should always be used to determine which treatments are acceptable and which are not. It makes a continuity of treatment, and it gets rid of ethical concerns such as scientific standards, effective treatment, and negative reinforcers.
The attack of standardization is that there's less individualization of treatment. It will affect Medicaid coverage. There are certain financial burdens, and ethical concerns aren't necessarily eliminated.
Again, continuity of treatment will ensure and standard quality of treatment regardless of location or proprietor. We want to have an agreement about what works and what we use. This way we can get rid of arguments about what the best plan is, or family members that come in and say, I have this miracle I want to try, miracle cure, I want to try, anything. Importance of it. So, according to evidence-based practice for children, youth, and young adults with autism spectrum disorders, to be included in this practice, the reports had to be clear, To include this review, the focus of the intervention practice and examining the study had to be behavioral, developmental, or educational in nature. Going through how much we're all agreeing on the same thing and how it would work. And also more important, these studies were only interested in interventions that could be practically put into schools, homes, or community settings.
There is already a standard of quality of treatment and continuity, regardless of standardization. This is why we have things like discharge plans. Practices are practical already because we rely on evidence even if the treatments are not standardized. With standardization, treatment will be less individualized. Clients need access to treatments that are effective, so analysts need freedom to change programs that aren't working and to customize them. They would not have alternative treatments if standardized treatments were mandatory. With standardization, it's increasingly likely that assessments will be used to determine which pre-formed mold the client can best fit, rather than assessing the client's strengths and weaknesses, making them more of a sorting hat than an assessment tool.
The Professional and Ethical Compliance Code 3.01 states that the type of assessment used is determined by clients' needs and consent, environmental parameters, and other contextual variables. With the standardization of evidence-based treatments, the assessments would no longer be as effective. And instead of those students being able to receive individualized treatment plans, they would then at that time be just kind of prodded into the best category that fits them as far as the standardized based treatment.
Individualization is still something that would still happen. No matter the kind of treatment we provide, we still have to think of our clients, what they need best, provide accommodations, and figure out best how to make the program for them. To again quote, evidence-based practices for children, youth, and young adults with autism spectrum disorders. The numbers of studies that support a given practice do not reflect the potency of the intervention, but does reflect the weight of research of evidence showing the intervention is indeed effective. The study is not interested so much as individual outcomes, just ensuring that this treatment is effective and works.
With standardization, treatments are less individualized, and there's a lack of replacement behaviors due to a lack of research.
We see that the Professional and Ethical Compliance Code 3.01 states that the type of assessments that are performed are standardized, but that is merely so that students or clients can be placed in the appropriate individualized plan for them. Treatment is evidence-based, but is individualized per student or client. With standardization, you would not have that ability to individualize the treatment for the child or the student.
Many treatments are not considered evidence-based under standardized criteria. They're only considered emerging treatments due to a lack of research on them. So things like AAC devices and picture exchange communication systems and even sign language don't meet the criteria to be evidence-based under a standardized criteria.
And according to the National Autism Center 2009, there are already several students who lack functional communication, leaving them unable to communicate with the world. Those augmentative and alternative communication devices would make a deficit even worse by standardizing the evidence-based treatment, since this is an emerging treatment and not something currently that would be viewed as a applicable treatment. There are some insurance programs who now will pay for the augmented and alternative communication devices for students who qualify. This enables this child to become this enables the child to communicate more effectively with their world and environment around them.
So, 3 major ethical concerns that will be taken out is, first, we are following code 1.1 code reliance on scientific knowledge. We are constantly trying to update our experiences and relying on evidence-based practice to ensure that our treatments are effective and make sense. Next, we want a treatment intervention that is FSC 2.09. We can say with certainty that the treatment interventions we're using are successful or produce significant results, and we can get out of that doubt or question that if something's not working, we know it's either human error or some other external incidence is happening. And one of the most important is 4.10, avoiding harmful reinforcers. The studies have shown that there is no significant harm done by these interventions. And again, as I mentioned previously before, the number of studies about these things, we can say that with certainty and know we're helping our clients and doing no harm.
We already rely on scientific knowledge. We're required to do practices that are evidence-based regardless of standardization. Treatment and intervention efficacy concerns are not necessarily eliminated with standardization, but they're lessened with using evidence-based practices.
As a BCBA, someone who's going to provide treatment, we have a code of ethics that we have to follow, which encompasses all of those currently, and evidence-based treatment is not standardized.
Medicaid coverage. Medicaid is more likely to cover standardized treatments and services, bringing treatment to more low-income families. It's a clear sign that people want clear results. They want to know they're getting the bang for their buck, and with standardization, you can say that. You can say the progress that they should be arriving, and you can show clearly that they are making progress and the milestones that they're making. Insurance companies want clear and defined results, and we can give them that. And it works best for everyone involved.
Medicaid currently only covers ABA services for the states that are in blue. Because of standardization requirements, the white states are not covered by Medicaid. If those standardization requirements were eliminated, there would be no standard exclusions, and everything would be covered by Medicaid.
According to the Defender News Service website, in 2017, it was stating that most Medicaid providers are requiring that analysts have a dual licensure to ensure that they receive qualify for their coverage, meaning basically that one license is not enough because of their standardization requirement. They have to have a secondary license that has the same requirements and a similar ethics code to the BACB. Basically, having a BCBA certification is already a national requirement and has this code of ethics to follow. However, in order to appease Medicaid and to have services covered, currently with the standardization requirement, you have to have not one, but two licensures to ensure that your coverage would be qualified under Medicaid.
The secondary licenses will have the same requirements and a similar ethics code to the BACB. Having a BCBA certification is already a national requirement, so the dual certification is redundant. If treatments were standardized, insurance companies would end up having more say in clients' treatments. Assessments would need to be tailored to determine which standardized packages would work for the client in order for insurance to cover them. In Texas, effective September 1st, BCBAs will need a second license to practice applied behavior analysis. Other professionals, such as licensed psychologists and teachers, may continue practicing behavior analysis without the license. So the dual licensure is only being required of those who have actually had training in behavior analysis. This is an undue burden on the BCBAs financially, and this could be seen as specifically targeting autism treatments, which is not allowed according to the Americans with Disabilities Act. The purpose of these requirements is to conform to Medicaid's standardized criteria, so Medicaid will begin to cover treatments in Texas.
The limits of research. Okay, as previously mentioned, the studies have not been interested so much as the individual outcomes, but the amount of research. Again, quoting evidence-based practices for children, youth, and young adults with autism spectrum disorders. The majority of the intervention studies over the last 20 years have been conducted with preschool age and elementary school age children. So, despite what the thing I just quoted, that wasn't interested so much as the youth, the adolescents, or infants. And those are some of the big limitations from the pro side.
Standardization does not clarify approaches and strategies. A standardization of treatment lists may not be relevant to a specific case and leave practitioners with an irrelevant EBP. Even without standardization, Code of Ethics dictates outcome measures and professional practices. Another limitation is there was little research on standardization of treatment from sources other than proponents. In conclusion, standardization of evidence-based treatments limits clinical freedom, limits individualization, and standard exclusions make it harder for families to get coverage. This also makes it harder for analysts due to dual licensure requirements.
And even with all of our references and resources that we utilize, such as Autism Speaks, the NCBI, our Professional Code of Ethics, several different articles, the National Autism Center, and the Defender News Service, it still relates back to the fact that it is not going to be best for evidence-based treatment to be standardized. We look at the top sources currently that most parents, providers turn to when looking up information regarding autism and various disability treatments, none of which are endorsing standardization of evidence-based treatment.
Use of evidence-based treatment is essential in ruling out untested therapies that may be dangerous, ineffective, or unethical to use. Instead, they identify permissible therapies. The behavioral therapist will still need to use their judgment in selecting appropriate therapy for a particular person with more than one evidencing practice is available. Professional judgment is still critical, but professional freedom does not include the right to use unprofessional methods.
If a school or clinic moved to standardize everything, do you think it is ethical to follow the standardization process given, but also include individualization elements? If so, what types of elements would you put in place to make sure that the standardized intervention was individually modified for your client?
We already have the ethical codes, as we've mentioned, that go through this. As we said, it's not one size fits all, and that we automatically, and then for doing our jobs, we automatically make accommodations, personalize, and individualizations for the person. If we're doing our job, we're already doing all this.
There's no need to standardize evidence-based treatment if, as analysts, we're following our professional code of ethics. That includes making sure that our treatment is individually based for our clients and that it is ethical and that it is what is best for our client in their learning ability and their learning style, whether it be in regards to their environment and helping them to generalization, their skills and transition. As far as if you're going to make a standardized evidence-based treatment have individualized elements, those elements, again, would come from our professional code of ethics. We're still looking at the individual consent, the individual treatment, the individual best treatment plan. We're talking about what is going to be best for our client as well as the family to have them more involved in their environment and have more awareness in their educational decisions as well as advancements in their life.
Has anyone worked with a standardized program of any kind in schools or clinics? Did you feel like this hurt or helped the client or student?
As of now, the three of us have discussed this question, and none of us have worked with a program that was standardized. However, we are curious to know if any of our classmates have worked with a standardized program in any school or clinic and how that affected your view as well as if it helped or hurt your client or student. I personally, my own personal opinion, I feel like if the standardized program was done in a school system or a clinic, you lose that individuality that you need for that student. As George Evans states, not every child can learn on the same day or in the same way. And so it goes the same as far as treatment. You cannot treat every child into a single mold. You're going to have children who break that mold or have exceptions regardless if it's an environmental factor, if it's socioeconomic factor. There's going to be something that you cannot force into a mold. So at this time, I feel like it would hurt my client or my student if schools were to go ahead and implement a standardized program regarding evidence-based treatment.
Thank you all for watching our presentation on the standardization of evidence-based treatments.